Good evening, Endo Summit Live, and welcome to an evening about miscarriage and pregnancy loss. Tonight, we are joined by two very experienced reproductive immunologists, both working in different sides of the field. And one is new, first time, Emma, on Endo Summit Live. Can
Hi.
you introduce yourself?
Of course. So my name is Emanuela Lazzaroni, but everybody knows me as Emma. And I'm a senior embryologist. I work many years with Dr. Vidali. And so I have a lot of experience in IVF lab. And I'm very happy to be here.
And not just with me, Emma. Like
No,
probably
no,
I'm
no. So he
with,
was the first.
yes.
Was the first, and now it looks like to be the last for me.
But also, Emma, tell everybody how you're connected to endometriosis.
So basically, I'm celiac. Okay, so let's start from there. And so actually, Dr. Vidali is the one who helped me to understand that I had these.
Please, we're on first name basis, Emma.
Yes.
If we all call each other first name, let's all be on first name.
Okay, Andrea.
Yeah.
Andrea basically was the one who let me understand that I had an autoimmune problem. Okay. So he also did a laparoscopy on me. And he told me, you know what? Actually, you are very inflamed inside. You have like these white dots, so everything. And then from there, I really figure out that I had an autoimmune problem, and I had before that several miscarriage, failed implantation. But then after we figure out everything worked, and I have two beautiful girls. So I'm very, very happy about, what we figure.
So not only an embryologist, but one of ours in our community as well.
Yeah.
And also joining us is that guy, the other half of the Endometriosis Summit. Dr. Andrea, you want to just introduce yourself quickly for those who may not have met you before?
Yes, I am a gynecologist by training, but sort of I've expanded my armamentarium in obviously surgery, which I've been doing for about 30 years, but also fertility. I'm a reproductive endocrinologist, and also immunology, which I think is probably the biggest thing, that one of the most exciting things that I have been working at. I'm very excited to be talking about this today because this applies not only to fertility, but also to many other things, right? Because we all say that immunology now is probably the most innovative area in the area of endometriosis, or one of, I guess, among the many exciting things that are happening.
Yes, as we tune in tonight, for those of you logged on to Zoom, and if you're not logged on to Zoom, that's where it's a happening. If you're logged on to Zoom, you can put your questions in the Q&A box. Facebook, LinkedIn, and YouTube, we'll try to get to your questions. We do answer the Zoom ones first, but Emma has a presentation for us tonight. Now, the presentation introduces something new that Zoom is doing, and it's very exciting. She's going to be the first one to do this. So, Emma, take it away.
Okay. So first of all, let's share, and then you will probably see me. Do you see me?
Yeah. Oh, wow. I love this, Sally.
Isn't that awesome?
I don't know how we made it this
Her
way.
husband did it. I'm like, oh, I never saw that before.
How do you do this? What
I'll
is?
show you after.
Oh my
Yes.
God.
So this is something new. So I'm supposedly I'm here on the right side, right? I mean,
Yes.
okay, perfect.
I'm so excited, Sally. This is amazing.
But we don't know how we did.
No, I know how to do it. We're 5 years in, so any advance in Zoom is very exciting.
Yes.
Okay, so we want to start, okay? And
Emma, put presentation instead of put present.
Andrea, stay out of it. This is how we're doing it.
Okay, sorry. Okay. I'm staying out of it.
So you see me, by the way, right? And you see on my background the presentation, right? Because
Yes.
okay, perfect. Okay. So as I already said before, when I introduced myself, my name is Emanuela Lazzaroni, but everybody call me Emma, especially here in US because too long, Emanuela. And I've been working with Dr. Vidali for a long time, and I'm part of SC team. I'm a senior embryologist and fertility specialist, and also fertility and endometriosis warrior as well. And so today we will talk about miscarriages, okay? And so let's say that miscarriage is still very often thought and explained with one simple idea. It was probably the embryo. So as an embryologist, I can tell you that this kind of explanation doesn't really match for what that I saw and I'm seeing in the lab or in clinical outcomes. Okay, so as embryologists, we embryologists evaluate the embryo development, morphology, timing, and in these days also part of the genetics across hundreds and thousands of embryos. So from that perspective, as an embryologist, certain miscarriage pattern cannot be explained just blaming the embryo, okay? So today, we want to reframe miscarriage in this context of IVF and the euploid embryos. And we show why genetic alone is not enough as an explanation. Okay, let's start. Okay, so let's start with the most advanced genetics available today. So a recent 2025 Nature paper used whole genome sequencing of pregnancy loss to look beyond chromosome number. So PGTA was not used in this case because they analyzed fetus and not embryos, okay? And so what this study from Nature show is that rare pathogenic small sequence variants in fetal genome can actually contribute to miscarriage. But when we really quantify these, variants, actually their estimated contribution is 1 in 136 pregnancies, so roughly 0.7%. So is it true that these genetics can cause miscarriage, but they are actually very rare? Okay. These actually variants are very, the events that these variants cause are very sporadic, not recurrent, and they are not actually screenable in IVF, so before the transfer, like we do with PGTA. So this, it cannot. So, but they do not explain repeated miscarriage patterns. So they do not count for the majority of losses that we see after euploid embryo transfer. So you can see that here is less than 1%. They count for less than 1%.
Emanuela, can I interrupt you for a second?
Yeah, sure.
Because a lot of REIs would say, well, yeah, the embryo is PGT normal, but maybe there is some micro deletion or something like that. This recent paper probably proves that this is not the case. They prove that they exist, but they're very rare.
Exactly, less than 1%. So, I mean, it's very tiny. Yeah. So let's check a little bit at this percentage again. And if we put together, we can understand better. So about 44% of loss are due to chromosomal abnormalities, okay? And a good amount of those basically can be screenable before. So less than 1% are due to these rare fetal sequence variants, but still we have half, so actually 55% of pregnancy loss unexplained by embryo genetics alone. So this residual category is where actually maternal and uterine biology becomes very important, very central. Okay, when you see this number actually greater, is in highlighted in yellow, greater than 99%, it's important to be very exact and precise about what it refers to. The previous Nature paper looked specifically at rare small fetal genetic sequence variants, not actually chromosome abnormalities. So those variants account for less than 1% of pregnancy loss. So when I say that 99% of loss are not explained by rare fetal variants, I'm not talking about just you know, I'm referring to this, but I'm not talking about chromosomal abnormalities. This has to be clear. It's not the same thing. So it means that once we account for chromosomal abnormalities and the rare fetal variants together, we still have a very large part of pregnancy loss that remains driven by non-embryonic factors. So that is why after euploid embryo transfer, focusing only on the embryo is actually not so appropriate. Okay, so as we said, even if, if we count all known genetic contributors, a large biological gap still remains. This gap cannot be filled by blame the embryos. So this is why after euploid embryo transfer, miscarriage should actually require deep investigation of the uterine environment rather than repetition of the same approach or IVF cycle. Okay, I know that everybody knows, but let's repeat. What is an euploid embryo? Euploid embryo has the correct number of chromosomes, so 46. So PGTA in IVF lab represents one of the highest level of genetic optimization we can actually currently achieve. Euploidy is assessed in the lab, IVF lab, by using PGTA through biopsy of trophectoderm at the blastocyst stage on day 5, day 6, and even on day 7, even if it's not, optimal. So this testing evaluates chromosome number only. So PGTA is only for chromosomes. And obviously it does not assess implantation biology, immune tolerance, or placenta development. Okay, all embryos tested with PGTA are frozen and transferred in a later cycle. So this separates ovarian stimulation from implantation biology. So when we have a miscarriage from a euploid embryo, we have to look at post-implantation biology. So basically what happened after implantation. So despite genetic optimization, miscarriage still occurs after euploid transfer. So across the studies, the rates remains around 10–15%, and this percentage is pretty consistent. So as you can see, clinical miscarriage rate 13.1%. So here there is an interesting randomized control trial that compare miscarriage from embryos with and without PGTA. And still we have pregnancy loss in the PGTA group. So definitely PGTA reduces chromosomal loss, but it does not totally eliminate miscarriage. And I want to be clear about something, because before confusion, that pregnancy loss rate that we see here, for example, you see 12.6% conventional IVF. Actually, it looks very low, but we have to understand that even without PGTA, I would say a very good amount of genetically abnormal embryos never implant. So they would never implant. And that's why they are not counted as a miscarriage. So PGTA definitely reduce pregnancy loss, but doesn't not completely, okay, eliminate. Loss that occur after implantation, they definitely, they are something that comes from, they are maternal or uterine factors. Okay, that was one trial, a controlled trial. But when we have the same miscarriage rate across the center and studies, we have definitely to accept that this is the reality and is not technical failure. So you see here that even between practice after euploid transfer, the rate remain always between 10 and 15% of pregnancy lost after euploid embryo transfer. So in numbers, if we translate in real life, out of 100 euploid transfer, about 14 pregnancy are still lost. So even if we do PGTA, we'll still have these 10–15% of pregnancy loss. When a euploid embryo implants, competence of that embryo is demonstrated, okay? But if loss occurs after, the question must change from why the embryo failed to why the environment where we put the embryo could not sustain it. So from this perspective, miscarriage becomes a fundamental information. So timing and recurrence can reveal underlying disease or condition, especially when loss repeat. What an embryo can or cannot do. Okay, an embryo can initiate implantation, but cannot regulate maternal immune tolerance, suppress inflammation, or remodel the vascularization of the uterus. Those processes depend entirely on maternal condition. So, early pregnancy requires a finely balanced immune environment. And Dr. Vidali will explain definitely better than me about this balance. So too much inflammation or inadequate tolerance can allow implantation, but prevent continuation of the pregnancy. So implantation and placentation are not the same thing. Actually, many euploid miscarriage occur after implantation, but before stable placenta development. So these are two different stages. So endometriosis, let's talk about endometriosis. So endometriosis is consistently associated with an increased risk of miscarriage. So even when, obviously, embryos are genetically normal, is actually what we have been saying until now. So this explains why patient often they get pregnant, but then they lose the pregnancy. So let's say that with endometriosis, implantation may occur, but maintenance may fail as well, maybe more often. So endometriosis is associated with a 30% increase in miscarriage odds, and adenomyosis shows a more than threefold increase. So both diseases have a big impact on miscarriage risk. Why? Because we have altered cytokines, impaired decidualization, and a chronic inflammation that actually can affect the pregnancy continuation, maintenance, even with, as we said, with a competent embryo, so genetically, let's say, normal. Let's say better, chromosomically normal. As well, anatomical factors may affect because may not prevent the implantation, but they can affect with vascular support and placentation. So as a consequence, affect the whole pregnancy. So when environment does not change, repeating IVF cycle often reproduce the same outcome because a change in embryos without addressing underlying factor rarely actually solves the problem. And from an embryology standpoint, a euploid embryo confirmed competence. Recurrent miscarriage reflects failure of support, not embryo failure. And I want also to say something else and make an example about this. So for embryologists, our culture, so where we grow the embryos is, fundamental in the lab. And we know that we have to use good incubators, the right pH, the right media, the right temperature. So if we fail in one part of this, the embryos can stop, can arrest. So the same thing happens after implantation. So if the environment is not appropriate, there is no way that, we will have success in a pregnancy. Okay, so after euploid miscarriage, an investigation should come before repetition of IVF cycle. So understanding what actually is happening, so biological factors must precede the fact of trying again or, and do repetitive IVF cycles. So in simple words, miscarriage after euploid transfer is not bad luck. It is a signal of underlying condition. So definitely genetics matter. It's very important, is a big part, definitely of a big reason of half, let's say, of miscarriages, but do not explain everything. So endometrial, immune, and inflammatory factors must be addressed as well. When embryo genetics are controlled, miscarriage becomes crucial and is not just a failure, is a good information. Okay, so thank you so much for listening to me. And here it's Dr. Vidali's turn.
Excellent, Emma. So excellent presentation.
Great.
Emma,
Yes.
well, thank you so much. Sorry.
welcome.
I thought you stopped. Please go ahead.
Okay, so I'm going to sum this up in non-reproductive immunology terms and just correct me if I'm wrong. So that article by Nature kind of says this need to blame everything on genetics is all bullshit. Is that correct?
Yeah, I would say that not all bullshit, but it's not everything, you know. So basically, we cannot always blame the embryo and so the genetics of the embryo.
So one of the, oh, I'm sorry, go ahead.
No, go ahead.
Okay. One of the things you said is we have to, if you've had a miscarriage, and you can't just keep doing the same thing over and over again. Is that correct?
Exactly. Yeah, you cannot, because as I said, it's like when I did the example of the IVF lab, right? And you put the embryo in a wrong culture media, it's the same thing. You keep putting in the wrong culture media, you still will have arrested embryos. So this is doesn't make any sense to keep doing the same thing if, you know, there is something underlying that we don't change.
Yeah. So now I have a question for Andrea. You know, you can change the environment for endometriosis in a couple of ways. Lots of REs like to change that environment with suppression. Do you think that really changes the environment so much? You have to stop your share, Emma.
Yeah, I will.
Yeah. So we
Well,
can
first of all, that's a great
Incredible.
question. That's a great question. And I think that it's not so simple and is not so proven yet. You know what I'm saying? I think that this idea that just by suppressing estrogen, we are actually achieving what we want to achieve uh, um, eh, is not exactly like that. There's probably a lot more to it, and I think that the key there, I mean, the key word there is that we still don't really know exactly uh, if these down regulations are actually work. I think there's actually conflicting information and about how how it's working. That's why even today I don't necessarily recommend suppression to everybody. Sometimes we recommend it because there is some limited data on it, but honestly, it's not that great. It really is not that great. I'd like to ask Emanuela a question. Emanuela, you know, whenever as an embryologist, you know, we always hear that embryos in endometriosis are dark. You know, we always hear these comments, but is that really a feature of just endometriosis, or is it also of any embryo of its poor quality? Do you want to tell us a little bit about that?
Well, I honestly, in my experience, I cannot say that embryos that comes from a person who has endometriosis they have specific features. Okay, I cannot. I mean,
oh, thank you, thank you.
No, absolutely. I really don't think so. I cannot. If you ask me, like, the word dark, they are dark. Some yes, some no. You know, there are not specific feature, I would say.
Right. Because people say, oh, they're dark because they think endometriosis, the chocolate cyst. So I think it's a very simplistic way of looking at it. And I believe it's told almost as a excuse to the patient. You understand that?
Yes. And also, actually, I'm going to ask you a question. So at the same time. So when we have these oocytes, okay, that come from the chocolate cyst.
Yeah.
Most of the time, those oocytes, I would say, they are not like amazing, okay? Mm-hmm. So we don't even get embryos from those.
Yeah.
You know what I mean? So if you have a patient that has an chocolate cyst, that oocyte usually is separate during the retrieval, okay? Because the doctors say, okay, so this tube is brown, so keep separate. We keep separate. And they don't actually, you know, we don't actually get embryos, or if we do, I mean, very few. But the majority of the other embryos that comes from that patient, they are normal. They don't have like a specific feature, as I said.
Yeah. Interesting, because it always gets said that way, and I've always sort of like wonder. You've heard that too, right, Sally? That people say, "Oh, the embryos are dark. The embryos are dark because of the endometriosis." I
No.
think there's more to it. I think it's more of an immunological problem.
Yes, also I agree. And I think that the fact that they say they are dark is just because they have this idea about the chocolate cyst, the
Right.
chocolate fluid, so that is dark. But the embryos, no. I mean, honestly,
Yeah.
no.
Right. And I have a few things to say. Sally, what would you like? Are there some questions that you like me to address, or you like me to say, a few things about?
No, do your thing.
Okay. So, uh, do I also get to share some slides, or?
Yes, if you would like to share slides,
Yeah.
you hit the share button.
Okay. And do I
When you
get
hit the share button, there's a
what?
new window that'll give you side by side if you're updated.
Oh my God. Hold on.
Like the one I
I
use.
mean, now he's going to be a crazy man with his talking head. You know, Andrea and a talking head.
No, hold on. I want to do the crazy talking head. That's what it's all about. Hold on 1 second. So I want to get 1 second, presenter layout.
Yeah, there you go. You see it? See, that happened today. Had Emma's husband not shown us that.
Is this happening already? No, I'm
Yeah.
not there yet. Hold on a
No,
second.
You go, then click your slides.
Hold on a second. I gotta click the slide here.
You click the layout you want.
Now, don't entire screen, application windows. Hold on a second. Application. Sorry, guys, it's just a second. I can't find PowerPoint. Here we go.
Hmm.
Okay.
Okay.
Okay. What is the new thing that I should see?
No, you should have done it before this step.
Okay,
Click the share button again.
okay. Okay.
And
what
then it should say presenter view.
present? Oh, I see that.
He and I,
Little
we joke, I
Andrea.
had the exact same reaction. Look at that.
Yoo-hoo.
Yeah, there he is.
Yoo-hoo.
You see me?
Yeah,
This is so exciting, guys. I don't, Sally, I'm like pumped.
I
But
know.
I don't
But
see any. Do I see everything now? I don't see little Andrea in the images.
Yeah, I didn't see me here before.
All right.
everybody's very excited online. We
All right.
see
Okay.
little
Sorry about
Andrea.
that.
Don't worry.
Okay. You
Also,
see me,
maybe
right?
we shouldn't be seeing little Andrea.
All
I
right,
don't
okay, good.
know.
All right. Sounds good. Okay. Fantastic. I don't see little Andrea, but that's fine. So what I'd like to talk to you today about very quickly is, this is a very specialized thing, but because we're talking about immunology is also um, something that is a little bit complex, but I think it's worth it because it deals a lot with endometriosis and what endometriosis is, and I think it goes all together. But I think that the most important thing is that we need to understand that endometriosis ultimately is an immune tolerance disorder. So endometriosis is not simply displaced endometrial tissue, like people say, retrograde menstruation, all that BS, right? We all know that it's very common for many, many people to have these coelomatic cells at the level of the peritoneum. And some people have a little bit, some people have a lot, but ultimately, why does this become endometriosis, the disease? Okay. Um, what happens there is that it's a failure. Endometriosis ultimately it's a failure of immune tolerance. And in a way, we can also say that some cancers, or certainly formation of cancer, is also a failure of immune tolerance. If you think about it, many of us have a lot of abnormal, very early cancer cells in our body, and immune surveillance destroys the cancer cells, right? And but we also know that, for example, immune suppression can cause cancer, right? We know that people who've had chemo, who are under immune suppressants are more likely to develop certain cancers. So the way we have to think about endometriosis is that endometriosis represents of a failure of immune tolerance of our body preventing the destruction of these early growths that come from the coelomatic tissue that actually develop into like lesions and then they grow. So it's basically so because it's a chronic inflammatory process, it has to be viewed under, in my opinion, the perspective of T regulatory cell dysfunction. And this is a sort of like a side note, but this year, in 2025, the Nobel Prize for Medicine was given to women, actually, who discovered T regulatory cells. I forget the name of the professors. I apologize. I wanted to remember it, but I forgot it already. But I think this tells you how important, right now the moment is also for endometriosis, okay? What is important about T regulatory cells is that they regulate the behavior of both macrophages and also natural killer cells. Why is this important? Because whenever we deal with endometriosis, we also understand that macrophages play a key role in endometriosis because they're sort of like the cleaners. And, and we know that, for example, in MCAS, in other, mast cells and macrophages are very important in endometriosis, also at a systemic level. And also natural killer cell behavior. We actually know that, interestingly enough, that in endometriosis, natural killer cells are low. They're not high. Why? Because there's a malfunction. So again, we're finding that there are some immunological traits of endometriosis that then reflect in other reproductive issues like implantation, placentation, and tissue homeostasis. So I think that kind of like everything comes together because I think this whole connection between endometriosis and pregnancy complication kind of comes to full circle in a way. Whenever you're dealing with why do T regulatory cells dysfunction? How do they dysfunction in endometriosis? There's not enough of them. They fail to eliminate the endometriosis tissue. And there's a persistent Th17 driven inflammation. In our study with Dr. Braverman, we showed that their Th17, the cytokine Th17 is the most important one when it comes to endometriosis and pregnancy loss. And also macrophage permissiveness. Macrophages don't clean up the inflammatory properly. The other thing that's important, and here again, we have estrogen dominance, so we're coming to full circle. Estrogen alters Treg differentiation and function. This is why we have to be very careful. We have to be very careful by giving estrogen, even in the form of oral contraceptives in patients with endometriosis. Because if the estrogen is not offset by adequate enough amounts of progesterone, it can be a problem. And endometriosis lesions produce their own estrogen. We know that. They produce it locally. I think a lot of people get confused with that. They think that endometriosis can raise your blood estrogen levels. No, this is a micro-local environment. It's not measurable, okay? But these self-perpetuating feedback loops sustain the disease and explain recurrent progression and chronic pain. Now, when it comes to reproductive immunology, current reproductive immunology focuses too much on natural killer cells. Natural killer cells are downstream responders. They are regulated by T regulatory cells. So this idea that we're just chasing natural killer cells is fundamentally a mistake. And I don't believe in chasing natural killer cells, especially peripheral natural killer cells. Now, I just want to say that endometriosis, let's conclude, because we talked about immune tolerance and endometriosis. Endometriosis is a disorder of immune tolerance, and it's centered in T regulatory dysfunction, and this is how it plays a role in reproduction. I'm sorry for I hope this wasn't too boring, but I hope I trigger at least some thoughts for anybody who's interested in reproduction and immunology. But now let's get to questions, maybe practical questions, because I think we have another 20 minutes and people may have practical questions to discuss, as opposed to sort of the bird's eye view that we just covered with Emma and myself.
Okay, excellent presentation and the little head. You liked being the little head.
I didn't see it, but I love it. I hope you
So
took a picture of it.
our attendees here, I want to remind you, you can ask questions in the Q&A, but they have to be theory related. Somebody asked a very good question, but it was related to themselves. Just rephrase the question, and we'll get to that if you repost it. What is the impact of lower stages of endometriosis on implantation and the miscarriage of euploid embryos?
That's Emanuela, you wanna answer or you want me to
Better
answer?
you.
Um, I would say that we have to be very careful, okay? The reason why we have to be careful is sometimes you have people, they do a laparoscopy and they find that the tiniest amount of endometriosis, like a molecule, literally. And these people and the patients have had recurrent pregnancy losses, infertility issues, and then next thing you know, they're like, that's the answer, it's endometriosis. Do I think that that's relevant? Probably not. You know, I think a lot of stuff happens when you do a laparoscopy. I mean, like, I think that we have to realize that there's a series of events that happen when you do surgery on people that changes the immune system, that there's antibiotics being given, there's actually endometrial scratching happening. There's a series of events that happen when you do a laparoscopy. And, people used to get pregnant even after diagnostic laparoscopy without endometriosis. So some of these pregnancies that happen immediately after minimal endometriosis may be due to the changes, the immunological changes that happen immediately after the surgery. So, although we like to take credit endometriosis surgery for removing a molecule of endometriosis, that may not always be the case. And I have to be very clear and honest about that. That doesn't mean it's sort of like you're getting credit for something that you did for a different reason or something like that. So I don't think that there's incredible evidence of very, very small amounts of endometriosis. When it comes to, I think really that when you have endometriosis, you have immunological issues going on. And really, whenever you're removing a lot of the disease, you're really maybe reducing the inflammatory load. And by reducing the inflammatory load, you're helping implantation. I think that's really what it comes down to. You're changing basically the immunology of the body by removing the disease. I think, and it's a theory, but I think it makes a lot of sense, Sally. But I like that you asked me that question because I feel that sometimes, people exaggerate sort of like the effects of removing very small amount of endometriosis, it may
Well,
not be true.
I want to point out the person asking is saying they have low stage endometriosis and diaphragmatic endometriosis. If you have diaphragmatic endometriosis, the train has left the building. You no longer have a lower stage of
Yeah, bad.
Right.
Yeah, you have stage 4.
Right.
Already
So in
big.
that case, I would suggest a better evaluation. But while we're at it, how does diaphragmatic endometriosis affect implantation? Is it just because it's a higher stage? What's the story with that?
Look, in order for you to have diaphragmatic endometriosis, it really means that your immune system is really off, right? It means that you have advanced disease, and it means that there's like obviously a very clear immune dysfunctionality. There's no question that the patients, it's very rare to, for example, to find diaphragmatic endometriosis. It's possible, but rare to find diaphragmatic in absence of significant pelvic disease. Is it possible? Yeah, but the rule is significant disease. And that's just like a greater disease burden. Let's just accept that one of the reasons why a lot of our patients who have endometriosis also have associated autoimmune conditions. And the interesting thing is that many of them, they don't know it because they will develop the autoimmune disease later in life. Let's not forget that a lot of the ulcerative colitis, a lot of the Crohn's disease, a lot of the other autoimmune conditions, even lupus, develops in women in their 40s and 50s. So it's possible that many of these patients who have these autoimmune predispositions don't know that they will develop these problems later in life. So let's not forget that we're dealing with an autoimmune problem here, and that probably in the future, a lot of the treatments for endometriosis will not be surgical. They will be focusing on immune surveillance, immune control, very similar to what we're doing for cancer right now. I mean, some of the best cancer treatments now are immunotherapies.
Yeah, on the live, we could say the word cancer a little less, by the way. So, Emanuela, my friend has reposted her question. So let's see if we can help her out. You mentioned in your presentation that endometriosis can affect vascular support during pregnancy. What is currently understood about the role of endometriosis and adenomyosis in placental development and fetal vascular support during pregnancy? Excellent question.
Yes, I think Dr. Vidali could answer better to this question than me. From embryology's point of view, is a little bit right.
Adenomyosis is probably the most understudied, undervaluated, and underdiagnosed condition that we have currently when it comes to recurrent pregnancy loss, in my opinion. And overall, also to pain, if you want my opinion. What happens with adenomyosis is even worse, in my opinion, in some cases. Obviously, this is not the Olympics of suffering, but it's even worse than endometriosis in some ways. The reason why is that the uterus is a very vascular organ. The uterus has incredible vascularization, like probably one of the most vascular organs in the body. And I mentioned that in the other live, is that because there's so much vascularization, whenever you have these inflammatory changes in the uterus, they create a systemic problem, but also locally there's a lot of spread, because what happens is that it draws in all these inflammatory cells very rapidly. And the inflammation, because it's contained inside a closed space, it causes tissue edema. And the tissue edema causes tissue compression, destruction, and hence at the basal layer of the endometrium, where those initial spiral arteries start forming, you start having distortion. You start having shallow implantation of the basal arteries, and therefore inappropriate placentation. That's where adenomyosis plays a major, major, major role. And I think that's really the key there. And so, yeah, it's a very appropriate question, but the mechanisms are multiple. I think that you have to understand. So, and they are hypervascularization that draws more inflammation, that creates as edema, that creates tissue distraction, and even greater inflammation. So that's really where it's at. But Emanuela, from an embryological standpoint, can I ask you a question? Because since we have an embryologist here, I think I want to take advantage of your presence. And, I know that often you guys, when people fail to make these embryos, they don't make it to day 5. A lot of centers are saying, oh, don't go to day 5, do day 3 embryo transfer. And I see it's becoming more and more and more common, especially for pregnancy loss, failed implantation. What's the story with that? Is there any, why are people it used to be something they did in the past, but it looks like it's it's becoming very popular again for some reason.
Well,
tell us is that true or no? Is
that true? Right? Actually, somebody asked me today about this. And so for me, there are several reasons why. So this is true. It was something that was more common, like I would say 10, almost 20 years ago, that the majority of the transfer were like day 3 transfer, okay? So then there was a time that nobody wanted to do day 3 transfer anymore, because there was this kind of obsession that is actually is a good obsession about blastocyst. So people wanted to go to blastocyst before doing the transfer, okay? But now there are I would say not every centers, but there are some centers that they figure out that maybe for some patients is more convenient to do a day 3 transfer because the embryos of that patient are not strong enough to grow in an incubator instead of in a natural environment like uterus. So there was, as I said, there was a time that everybody wanted to go to blast, so they didn't do anymore this day 3 transfer. But now some centers, and I would say pretty much like many recently, change a little bit about this idea that they have to go to day 5 no matter what. And, they went back to day 3 transfer because they think that for some people they do not have so many strong embryos, probably the natural environment is best.
Do you think it's true?
I think that it's true.
Have you seen it? Have you seen it?
I think it's true for certain centers. I mean that probably like a lab director of a center or like the doctor, they know that their culture is not so appropriate for those people that they have kind of weak embryos.
Hmm.
So,
Interesting.
yeah, I think that, because there are some, statistics in every centers, and they figure out that, they say, okay, why these kind of embryos for people who, I don't know, has that age. Let's say, for example, like in a certain age, they don't actually get to blast. Why we have so few? Probably something wrong in our culture.
Really interesting.
Not necessarily is wrong, but is not appropriate for that kind of population.
Very interesting. I didn't think of it in those terms because big centers who have a lot of cases, they could probably run down the statistics very well and they keep track of that, right?
Yes. But every center has its own
Problem.
culture and problem,
Interesting. I didn't know that, Emanuela. You're actually telling me something I didn't know.
It's not every center use the same media, has the same incubator. So especially now it's very different than 15, 20 years ago that we use always the same incubator, the box incubators.
Right.
But now there is the embryoscope, there is the embryoscope from ESCO, from Vitrolife, from this, from that. So they are different. So
you do a lot of consulting. When you go into a center, they tell you this kind of stuff. They tell you, okay, for these type of patients, you do day 3. Do they tell you?
No, they don't really say, but I think that this thing coming out later. So when they review their cases, they figure out.
Oh, I see. Okay.
Yeah.
Interesting.
Yeah, I think that sometimes I believe you have to follow your practice suggestion. Because if somebody tell you, well, why don't you do a day 3 transfer? Probably there is a reason why they say that. Not only a reason because, they think day 3 is better than day 5, but because probably they know how, their culture, their incubators, their everything in their labs works.
Yeah, that makes a lot of sense. Well, that was extremely interesting.
Okay, I have a couple more questions, and I know you like to leave, but we're going to run over. You're going to stay.
I'm staying.
So, okay, this is the scenario. Patient has a right-sided endometrioma. They've had multiple failed rounds of IVF, let's say 3. But reading online, she says her IVF specialist never mentioned endometriosis to her. Now she realizes an endometrioma means endometriosis. The IVF specialist says, let's go for round 4 but we'll change the cycle by suppressing first. Or she has called and she wants to do excision surgery. What do you choose? Like at that point, three miscarriages in, what do you choose? You choose to do excision. And wait, the endometrioma is over 4 centimeters. Let's just make it easier.
Well, the first thing I would say is data shows very clearly that suppression before stimulation does not help. So there's zero evidence that doing medical suppression prior a retrieval is of any benefit to the patient. In fact, it is potentially detrimental because you're basically saying 3 months before a stimulation, you're wasting 3 months basically, and time is, very important in when it comes to fertility. So I think that first consideration very, very important. There's no benefit in suppressing. Is there benefit in banking those embryos? The answer is yes. So even if you had the miscarriages and you have no embryos, there may be benefit, even if you have an endometrioma, to bank some embryos, depending on your age. There's so many variables, but especially if you're a little bit older, it's probably a good idea to have some embryos banked. If you're younger, different story, because then maybe the cause of your fertility is the endometriosis, so it's better to remove the endometriosis. So I think that the answer to that, if you've had 3 miscarriages, you're having, and depending on your age, you're having recurrent pregnancy loss, and you need a workup. You need a hard stop and figure out what's going on. You need to go back, review the embryology, right, Emanuela? You need to see
Correct.
what were the embryos like. You need to do like a sort of like a timeout, if I will, and see exactly what's happening. Were the embryos poor quality? What's going on? I think that's really a very important consideration. Because, for example, if you had miscarriages and you had like very good quality embryos, that's more worrisome. You know what I'm saying? If it was a day 7 embryo, maybe you're less inclined to think that, right? And then, that's what really kind of like makes you the decision on the surgery, whether to do it or not. But yeah, I obviously think that if you have significant disease and pregnancy losses, you have to look at everything. And also at the immunology, at least some look at it. At a minimum, look at your health history. Do you have lupus? Do you have a family history of autoimmune disease? Do you have celiac? I mean, you got to look at all that stuff when you have 3 losses. You can't. Do you have insulin resistance? How about that? I see a lot of patients having losses and they have really high AMHs. They have a high hemoglobin A1C, and nobody ever gave them anything to correct that. That's pure inflammation. Insulin resistance is inflammation. These people may need a GLP-1. They may need also metformin before they even do a transfer or even another retrieval. We have to look at all that stuff, which is all tied together.
And at what point do you move to surgery?
I think surgery, after all of that is done, then you can talk surgery. I think that it has to be an analysis and you have to sit down because, for example, I saw people like this weekend, and yes, we planned the surgery, but I also started them on Ozempic or Mounjaro, depending. I started them on all this stuff because I said, there's no point for you to do the surgery, waste 2 months, and then in 2 months we deal with your insulin resistance. What the heck? Take advantage while you're recovering from the surgery to fix your metabolism. I think that this is why it's very, very important to look at the patient holistically and not just from the perspective of surgery, yes or no. You got to look at everything. But yeah, the surgery has to be done, but let's look at everything and do everything at the same time, guys. Let's not just waste months, that could be used to fix other problems.
Excellent. Okay, we have a question about endosalpingiosis.
Right.
How do you feel that impacts fertility?
Nobody knows. I can tell you that endosalpingiosis is a tricky thing because I've seen horrible endosalpingiosis and I've seen very minimal endosalpingiosis. One of the big concerns is that a lot of people, there's some thinking that that ovarian cancer can originate also in endosalpingiosis, so that's a concern. But overall, I think a small amount of endosalpingosis, probably not a big deal.
All right. Do you typically recommend surgery prior? So somebody has endometriosis, I'm assuming. Do you, and their goal is fertility. Do you recommend surgery prior to trying to conceive or waiting until after you try, but possibly experiencing a miscarriage?
Depends on the circumstances, like there isn't like an automatic answer.
Mhm.
I think that if you have minimal endometriosis or a tiny endometrioma and you've never tried to get pregnant and you're young, I may tell you, hey, try for a few months and then we'll do the surgery later if you're not successful. I don't necessarily feel that doctors have to have this knee-jerk reaction, jump into the surgery. I think everybody's different, so and some of it depends also on the patient's perspective, but I would say that it would not be unreasonable to try to conceive. And it's not automatic that you're going to have a miscarriage if you have minimal endometriosis. So, but there are people, for example, who have the endometriosis that is symptomatic and they have dyspareunia. They can't have sex. I mean, those people need to have, you have to look at the patient, at the whole situation holistically, because if you do the surgery, you get the benefit of the surgery in ameliorating the pain and also increasing the fertility. But, we have to look at, like I said, it has to be done with an in-depth analysis, not just like that knee-jerk reaction. We don't rubber stamp surgery. That's the way to look at it and think of it.
How soon can someone post excision start to try naturally, and how soon can they return to IVF?
A month later, basically 2 periods you're
It
talking
was
about.
two different questions. A month later for both?
Yeah, absolutely.
Yeah, I think your friend Dr. Gargiulo disagrees. I've had this conversation with him.
Look, it depends on the things, but we agree to disagree. I think Antonio is a very he's I would say he's a very conservative doctor. I'm a little bit more aggressive. I kind of feel that people who are trying to conceive are under a lot of pressure, and I like to let them to go back to trying as quickly as possible. I feel that 3 months can feel like a lifetime for somebody who's trying to conceive.
Okay. All right. Excellent. I know
Let
that
me
there,
ask about adenomyosis without a hysterectomy.
we're not gonna, we're gonna just let me sum
Oh,
up the
sorry,
way.
sorry, sorry, sorry.
Okay.
I apologize.
All
Sorry.
right. There are a number of questions left. I want to direct you to our YouTube channel. A lot of these questions that you're asking are over there, particularly the ones about PCOS and endometrioma. We will have a separate video on GLP-1, but that has been covered actually in every night that we've had. You can find something on the YouTube about that. As we wrap up, somebody has a question about adenomyosis and hysterectomy, and avoiding hysterectomy, and we have a 2-hour session on that at the Endometriosis Summit. Do you want to hit the highlights on what is the emerging field in treating adenomyosis that we are going to go into depth? Actually, Dr. Miller is going to come and do a big presentation. You have a big presentation. Dr. Ceccaroni has a big presentation at the summit, but you want to hit the highlights on that?
All I want to say is that for the longest time, we always thought, oh, we do nothing about adenomyosis. Either you have a hysterectomy or forget about it. And I think that this has been a huge limitation of what we do so far, because I feel that adenomyosis plays a huge role, not just in pain, but also in reproduction. So a lot of work has gone into trying to treat this disease, which is ultimately a soft tissue disease. And people have been thinking, wait a second, we're treating prostate cancer with non-invasive ablative or thermal therapies. We're treating liver mets. We're treating all sorts of soft tissue diseases. Why can't we treat adenomyosis in the uterus? And so in the last, I want to say 4 or 5 years, a lot of work has gone on in this area. And So there are techniques like microwave techniques, radio frequency ablation, HIFU. There are now becoming more and more developed. I personally have a lot of experience now with the microwave, and I personally like microwave therapy, but there's tremendous literature on this. And I feel that in the United States, we're falling behind. In Europe and in Asia, they are really managing these conditions very aggressively. But you need to come to the summit because that's where you're going to get all this information. That's where you're going to get the opportunity to talk to the doctors, to talk to the providers, to talk to the ultrasonographers, and you'll find it extremely interesting. So come meet us in Orlando on March 27 to 29th. Did I say it right, Sally? 27?
Yeah, we keep getting
Right.
it wrong.
Yeah,
Mhm.
27 to
So,
29.
wait, there are so many questions about fertility. Emma and I have a new project for you. Emma, you want to tell everybody what's going to happen?
Yes, so basically soon we'll start our fertility, still related to an endometriosis summit, our fertility webinar. And we will have 6 episodes, right? And yeah, and it's gonna be actually amazing. It's gonna be really more fertility than we did today, but it's gonna be nice. We have a very interesting guest already, right?
So the
Emmanuel,
problem was, if we want to do fertility, we could do like maybe 1 episode or 2 episodes in the 13-week season. So Emma, now that we have an embryologist with us, she could do a whole season. So we're going to do 6 extra episodes. They'll air before the regular episodes, starting sometime in February.
Yeah.
So like the fertility ones will be 6 to 6:30 to 7:30, and then the other season will be 8 to 9. So I'll have no life. I won't eat dinner. It's fine. But this way, all these questions, like I know people are out there in the Q&A and they feel like this is the last chance they'll have to ever ask this question of an expert. No, no way. Now we're making you a whole season.
Exactly. It's gonna be nice, and we will answer all your questions.
And also,
and Emma, I would love.
Emma, can you tell everybody a little bit about the program that you run? I don't care about him.
Oh, on Essie, you mean? Yes. So at Essie, we just start together with Dr. Vidali, with Andrea, let me say, otherwise, with Andrea, this section that is called Essie Fertility and Immunology. So our patients that they are like going through endometriosis will be also evaluated under fertility point of view, pre-surgical and post-surgical. So I'm gonna review all their fertility. If they did IVF cycle, I will review the reports, the PGTA reports as well. And also we will take a look about the immune factors. So it's something new, something that is coming now at Essie, and we are actually very excited about it.
Yeah, so you get like a fertility deep dive.
Yes.
Yeah.
Exactly.
Very needed because, like we said tonight, that surgery is very important, but it's not the only thing.
Exactly. And also, even before surgery and after surgery, this is very useful.
I want to point out that when Emma came on and I said, Emma, really introduce how you're connected to our community. She didn't say, oh, I have endometriosis. I had all these miscarriages. The first sentence was, I had celiac.
Yes.
And I think the deep dive that you're talking about doing is a way to analyze all these things and bring them together.
Yes, exactly.
Emma,
now you can.
What would be amazing, Emma, if you told your story, because your story is like,
number one.
I want to reveal we're friends also, Emanuele and I, so I know her story, but I think your story is a story of defeat and success, and I think that I think that would be very inspiring. I would love you to do that on one
I
of the
will.
episodes. And also, I would love you to maybe, if people send pictures of their embryos, that you look at people's embryo pictures, you could do like a marathon session of looking at embryos. It would
That
be
actually would be so super cool.
that would
I
be
would,
so much fun. What do you
yes,
think, Sally? People send us pictures and she looks
and
at them.
say nice, bad, okay, good.
We would have to look into the legal
Oh, it
ramifications.
would have to be anonymous,
Yes,
private. Yeah, anonymous.
She could probably collect them on Instagram
Yeah, okay.
even.
and somehow remove the data
Yeah,
Mhm.
and then go through
just
it.
a
But
picture.
I know, like I always add this, and I don't mean to take away from anybody's success, but I always say there's another side to the coin when doctors like to measure a successful person by how many pregnancies that they've had post treatment. That
Mhm.
the other side of the coin is there are people out there, myself being one of them, no matter what you did, there was never going to be a child. So we don't ever want to alienate
I
anybody
know.
by saying one thing is a success and one thing isn't a success, or somebody's story has more power than anybody, because we all share the same community.
That's true.
Yeah.
That's true.
But we will work on getting the embryo tail together. That sounds like a good idea. And if you have now, we have a GLP-1 and pelvic pain session coming up, but we don't have a GLP-1 and fertility webinar specifically. And we could add that to the season as well.
I would love that.
Yeah,
Yeah.
good, because you're probably going to have to do it. So, coming up, I want to tell everybody that's here, the Endometriosis Summit will be March 27th through the 29th. I will tell you now that certain parts are more than 70% sold. Some of the labs, some of the parties. So if you're looking to purchase tickets, you should do that. It's in person and it's online. We end every time this way. But Emma, what are you looking forward to the most about the Endometriosis Summit?
Well, first of
Going to
all,
Disney.
of course, no, 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 nightmare.
No, I'm just joking.
No, actually, I'm looking, first of all, to meet a lot of people that are very experienced in this field. And as Andrea, as other doctors, and also not only doctors, but therapists, everyone. I think that, so last year was my first year at an endometriosis summit. And honestly, it was so amazing that when I think about that, I'm smiling. Because
By the way, Emma is going to do a session that's a patient Q&A on fertility. We forgot
yeah,
to mention that. Last year, she kept such a low profile, but this year, a session with Dr.
it
Vidal.
is mine, okay?
Yeah.
It's
Yeah,
gonna
it's
be
her
mine.
session this year.
Yes, my session. No, I'm very excited because first of all, it's a happy meeting. I mean, that is the main thing. It's not a typical meeting where, only doctor join and is a little bit, no, everybody is there smiling and try to help each other. So it's really, really beautiful, the way how we make friends, and I'm very, very excited that I really be part of it this year.
Yes, yes. It's funny, Dr. Vidali, Emma, and I, we all went to a meeting, and Emma just wanted to hear one lecture. And no matter what we did, we couldn't make that happen. And I'm thinking when you talk about the Endo Summit being such a happy meeting, we would always get the information to somebody. If somebody wanted it that bad, we make sure
Everyone.
they get it.
Yes, yes,
Yeah.
exactly. No, it's a very, it's a wonderful meeting. Wonderful.
All right, Dr. Vidali, and what are you looking forward to except for no more texts at 4 o'clock in the morning about what I need?
Well, first of all, I have to say, I see that new directions, I see that how the summit is always ahead of its time, in the sense that, and I have to say, thanks to Sally, who actually does all the research and finds the best people. you know, I discover things, I discover people that I didn't even know existed. I discover specialists. You know, she really goes wide and everywhere worldwide to find the people that are on the forefront, and she brings them there. So that's what I'm curious to see what other, you know, ace up her sleeves Sally's going to have in the amazing people that she brings up to the summit.
Yes, and we're already planning based on these lives. We're going to do 2027 is going to have an immune workshop day.
Yeah,
Yeah.
exciting.
I will say, for those of you that don't know, I am very much looking forward to. I spent 2 full days designing and coding our Press Your Luck game, which we'll play on Saturday morning. And I'll tell you, we have 50 categories in endometriosis and over 250 questions, and we're all going to be yelling no whammies. It's going to be great.
Fun.
Amazing.
You two were not raised in the US. You probably have no idea what I'm talking about.
Oh, but we're
You'll,
excited anyway.
you'll
Yeah.
learn. Okay, next week, we're here with Dr. Bagaria. I love
Oh,
her. She has an amazing TikTok. If you haven't seen it yet, love her TikTok. And she will be talking bowel endometriosis next week. And don't forget to sign up for the Endometriosis Summit, either virtually or in person before it's sold out. Take care. Good night, everybody.
bye bye,
Thank you.
guys.
Thank you,
Thank you.
everyone.
Bye bye.
Bye-bye. Bye.